You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtyna.com. Dr. Noor, I am so excited to have you on the Dr. Tina Show. Welcome. Thank you for making the time.
Thank you for having me. I'm thrilled to be here.
Yes. Well, you are one of my favorite Instagram hormone gurus. So if you could introduce yourself to the audience and then we'll jump in.
Sure. My name is Dr. Noor Al-Humaidhi. I'm a family physician. I am originally from Kuwait. I grew up in Kuwait and I went to medical school in Ireland and then lived in the UK and moved to the US in 2017 when my husband got a job in Boston. And so we've been here since then. And I was kind of doing my primary care family medicine thing. And after COVID hit, I developed, and I'm sure we'll talk about it, what turned out to be perimenopausal symptoms. And that sent me kind of on a journey to figure out what was wrong with me. And then as I figured out what was wrong with me, realized that there was this huge gap in treatment and care that women were missing out on. So I started my own practice called Lifestyles by Noor, kind of on the side, just to kind of get care to people. And that has really grown from strength to strength. And yeah, it's taken over my life.
Well, I love it. I've watched your journey. I think I found you when you came onto Instagram early, and it's been so fun watching not just your Instagram grow, but watching your brick and mortar grow too. And it looks like you guys are doing incredible things for women. So very cool.
Thank
Alrighty.
you.
So I think of you as like the ultimate hormone misinformation myth buster, because whenever there is some nonsense floating around the internet, you seem to keep your composure. You're usually doing your skincare while you do it. And you just throw down, and it's so elegant and it's so well spoken. And so I thought we could just talk about some of those common misconceptions that are floating around out there about HRT. And then you have a really similar story to mine as well about how perimenopause hit you. And I thought we could jump into that too. So let's start there. Talk about that, because you've been really transparent on Instagram about how the whole process happened for you.
My really significant symptoms started in 2020. So in 2020, March, COVID hit and they closed our practice, and I opened what they called the respiratory clinic in the hospital. So it was like a COVID clinic, somewhere for people to go that were having respiratory symptoms, where we could treat them and we could test them, etc. It was stressful. We didn't really have PPE. We didn't know if we needed PPE. It was, a very uncertain time. And I've always had some anxiety, but I became so anxious and I suddenly stopped sleeping. And I am somebody that can sleep. I mean, I grew up in Kuwait, so I'm allowed to say this, but my mother would have said, "Oh, Noor can sleep through an air raid." And it's true. I could sleep through an air. I mean, I was a sleeper. I could sleep anywhere. All of a sudden I stopped sleeping. I could fall asleep, but I couldn't stay asleep. But then when I woke up in the middle of the night, I was panic stricken, and I was probably having auditory hallucinations. I really believed that somebody was in the house. I believed that there was water gushing, that somebody was at the door, that there was a fire. And I would jump out of bed thinking that, the children were going to die, and I was in the basement. I'm sometimes outside thinking that there was an intruder. It was awful. And on top of that, as somebody that has taken, went to medical school when I was 17 years old and took every exam under the sun. Like one thing that I could say I can do well is use my brain and remember things and study. I had a photographic memory, and my brain left my body. I could not remember anything. I couldn't remember what was happening yesterday. I was forgetting to pay bills. I was forgetting to pick up my children. And that's just not me. My brain couldn't work. And it was for my husband, as somebody that I took care of everything, not because he couldn't, but because I took care of everything because I remembered everything. And he was like, "What is going on?" And I thought I had MS. I thought I had dementia. I thought I had long COVID. And I saw neurology and psychiatry and all the things, and they did all the things, and I wasn't better. And it was scrolling at 3 a.m. in the middle of the night because I couldn't sleep. And I saw something I think it was on Instagram, and it was just something that kind of just like was a catalyst and made me think, wait a minute, is this perimenopause? And that sent me on a journey of discovery. And what I learned was that I didn't know anything about menopause and perimenopause. I knew dry vaginas and some hot flashes, and that was pretty much it. I had no understanding that perimenopause could present with anxiety, insomnia. I had no understanding of that. And so I joined every WhatsApp group that would have me. I read every book that I could read. I went to every conference, and I really gathered knowledge over the next couple of years. And initially I did the work in my own practice at my primary care practice, but it wasn't well received by my colleagues. They didn't want to refill the medication that I was prescribing. And so it just stopped working. And as a result, I kind of stepped out on my own. But for me, it was the mental health and those brain symptoms that were just debilitating. And I often reflect back on that time and I think, I'm just not sure I would still be here. It was that bad.
No, I hear you. I had a very similar, I think that's what caught me. I saw you talking about that on Instagram and I just started bawling because I was like, that is exactly what happened to me. And I didn't so much have the hallucinations as I got crippling spinal and joint pain. And I've always had chronic pain ever since my daughter was born 26 years ago. I've always had some level of chronic pain in my SIs. I'm kind of an autoimmune girl, so I've got that like chronic SI low back thing. But I pride myself in staying very fit and love strength training and was probably in the best shape of my life when this hit me. And I ended up crippled. And I spent probably a year, anytime I wasn't having to be working, I was laying down. I was laying on a couch somewhere trying to just get the pain to stop. And I think prior to that, my memory really started slipping to the point where my team who'd been with me a while, some were new and some had been with me a while, were like, what is wrong with you? We told you this. We told you this. I sometimes I'm usually pretty calm, but sometimes I would even light them up and be like, why isn't this done? And they're like, we did it. We had a conversation about it. And I was like, oh my God, am I getting dementia? What is happening to me? Is this just stress? Like, what is going on? And then, finally, my daughter put it together. She's like, I think you're going through menopause. And I'm like, but I'm cycling. And I also had the most flat affect. I've had depression and anxiety on and off throughout my life, but this was not even depression. It was like I gave 0 Fs about anything. I was just done, flat. And I nothing. I couldn't invoke joy. I didn't want to have sex. I didn't want to do anything. I wanted to get in my car, take my dog. I love my dog to death. I love all my family members, but like I really love my dogs. And I was like, I'm just taking the dog and I'm going to leave. And I wasn't even sad about it. I was like, I'd probably get to the border of, at the time I was living in Oregon, I'm like, I'll probably get to the border of Oregon and just not even, maybe I'll cry then. I don't know. I like couldn't even muster up a cry. That's how flat I was. And put estrogen back in the picture. And it was like, the sky opened and the clouds lifted, everything was lovely. So it gets my goat when I hear other women, older women on Instagram, when they're like, oh, you don't need hormones. I raw dogged it. I'm fine. And I'm like, there's no awards for raw dogging menopause, lady. Like, I'm glad you're fine. But a whole generation of women got completely hosed by that Women's Health Initiative study. And then number two, when I see, this one really gets me. When I see male doctors, usually younger, and younger women too, just bashing on HRT. And I'm like, just because a lot of them are I'm a chiropractor. I'm a naturopathic doctor and a chiropractor. I've been using HRT in my practice predominantly for musculoskeletal complaints. I never stopped. Like that Women's Health Initiative never stopped me. I just always was taught from the early 2000s how to apply it for musculoskeletal complaints. So that was the majority of what I was doing. And I was seeing such profound, long before we had the literature, long before the term musculoskeletal syndrome of menopause was coined, I was using estrogen and testosterone and progesterone for all kinds of musculoskeletal complaints and seeing just profound changes in women's health and changes in the texture and the integrity of their tissues. Like I was feeling it in real time. And I just didn't realize that a lot of doctors don't know that and weren't doing that, until I opened my mouth on Instagram and just got obliterated by people. So anyway, it's been an interesting ride on my side too. And there I was in chronic pain and couldn't even identify it myself because your brain's not working well enough.
Did you have a lot of postpartum symptoms or not really?
Terribly.
Yeah.
Terribly. I spent about 9 months hallucinating, like literally hallucinating. I thought there was a particular image of a man's face I had in my head, and I was convinced he was trying to kill me and my daughter. I was convinced he was at my apartment door. I was afraid to take a shower. I'd bring my giant dog into the shower with me and bring the baby into the bathroom with me and then take a really quick shower because I was convinced he was going to try to murder me. And it was crazy. So yeah. Definitely. It was terrible. It was not fun. I've always been low
so
estrogen
sorry.
though. Like I've always just ran really low hormones. So I think when it started falling out, it just fell out. There wasn't a
You were
lot of
barely
leeway.
there anyways. Yeah.
And I don't do great with it. I tend to go down that 16-OH pathway, and I have to be careful, and my lifestyle has to be really dialed in for me to even tolerate estrogen. But it's been interesting, and I have to say, as somebody who was prescribing hormones for a long time, I really didn't appreciate and understand what these women were going through, and men too, as their hormones fell out. I really wasn't appreciating it as much, of course, until you go through it yourself. It changes everything.
It totally changes everything. And, you mentioned about, I see women a lot, or they stop me outside because, menopause is my personality, and I'm out and about, and somebody will stop me and say, even last night I was at an event and a woman was like, oh no, I sailed through menopause. I was great. And then you start to talk to them and they're like, oh, but I take Ativan to sleep, and, I'm on duloxetine for my joint pain and my neuralgia. And you're like, you didn't sail. You just didn't give it the right name.
Yep. I had a client recently who started, I always start people on progesterone first. That tends to be the one that, you get a lot of bang for your buck, and it's like it's the way to ease folks into HRT and get them to be a little more comfortable with taking it. And when we finally got the estrogen on board, she could not believe the amount of pharmaceuticals that she had been given over the last 10 years, plus to mitigate all these symptoms that were easily remedied and handled with the progesterone and estrogen. And it's just, I hear that every single day from people, particularly around antidepressants, anxiety medications, sleep
medications. Yeah. And you know what, the one that really gets me and that has me ranting on the internet is, the anticholinergics for urinary symptoms. It just makes me crazy.
It's crazy.
That's first line.
It's like crazy.
And then they're falling, and then they're breaking. And then, as somebody that's worked in, older care medicine my entire career, it's just these should not even be FDA approved, in my opinion. Like, what is going on? You should not be allowed, until you have adequately treated somebody with hormones, you are not allowed to give them an anticholinergic drug.
It's crazy. And the genitourinary symptomology, especially in older women, they don't even feel it often. They won't even report symptomology of a UTI. They just all of a sudden, so I was doing regenerative joint injections. That's predominantly what I was doing. And so before I would inject a joint, I was like, if they even had a glimmer of, if I had a glimmer of a suspicion, I would make them do a UA and look. And I'm like, you have an infection. Oh, I didn't know. I didn't feel anything. But you can tell because they're starting to get like the low-key dementia. And it's just wild. But they'll throw oral birth control at anyone. It's just, I remember walking into Planned Parenthood when I was like 14, 15 years old, way back in the day, because I'm 52 now, and they'd be like, do you want some birth control? But God forbid we give a menopausal or a perimenopausal woman. Let's talk about that. So I really am a big fan of handling this sooner than later. I'm a big fan of addressing it while they're still menstruating and addressing whatever hormonal deficiencies are present and dosing at physiologic levels, not necessarily, I'm not going for heroic levels. How do you approach a patient? And are you a fan of starting earlier than later?
I'm a fan of starting earlier than later. And I'll tell you, I treat women, even younger with PCOS, PMOS now, and, PMDD. I treat them with bioidentical hormones. They do great, So I've got a 17-year-old on bioidentical hormones. She's doing beautifully. So I don't think there's some sort of time frame at which you're allowed to use bioidentical hormones versus birth control. Because previously that 17-year-old that I see would have been put on birth control, or she was put on birth control and wasn't better. But I don't think that there's a too early. I think it's when you're symptomatic, and if your hormones are low and it all jives and makes sense, then we should be treating you. And we know that a lot of those metabolic changes and the bone changes that are going to happen long before you notice changes in your periods or you stop having a period. So we're missing, if we use kind of menopause as it's currently defined as the point in time at which we start somebody on HRT, we've missed a huge window of potentially saving their metabolic health, reducing their visceral fat, reducing their cardiovascular risk, improving their bone density. And, we know at least 5 years, but I would say longer, 10 years. As soon as you're symptomatic, I think you should go on HRT.
And what are some of those early symptoms that you're seeing in people?
So mental health symptoms, so increased anxiety all of a sudden, sometimes I'm fatigued. Women will be like, well, I just like 3:00 comes around and I just can't get out of my own way. And that's new. I'm suddenly irritable with my kids. I have rage. I've never had that before. Feeling flat and depressed, maybe waking up in the middle of the night, joint pain. I mean, that the symptoms are potentially, any symptom is a perimenopausal symptom. But I think a lot of women ignore those early, I'm irritable, I'm ragey, and they misassign it as stress in their life because often it's a stressful time in their life. They have more than one child. Maybe they're in the sandwich generation. They're maybe at the peak in terms of their job. So they have a lot to be stressed about. So they blame it all on stress instead of addressing the elephant in the room, which is their hormones.
Absolutely. Yeah, that rage piece. That's a big one.
A thing. Mm-hmm.
Yeah, let's talk about that because it is rage. I have felt rage. It.
Yeah. I've had women come in and say, I don't know who this is. I lost my mind. I was in the car with my kids or I was, and they'll be like, I'm so ashamed to tell you what I did and what I said to these children and and I'm like, it's not you. It's okay. It's your hormones. But rage is a huge component of perimenopause. And I often tell people women often are cycling normally when they start to have that symptom, and it'll be the week before they have their period first. And they'll all of a sudden have this rage. And then that will get longer and a little bit longer and a little bit longer. But, women this is the other thing. They hide it. They're ashamed that they behaved that way and that they think that they've lost sight of themselves and they don't tell anybody that this is, I don't want to say the word normal, but this is expected with the loss of your hormones and can be attributed to the loss of your hormones, and we can help.
It is, I lost my mind. That's the term. I lost my mind on my children. I lost my mind on my daughter. And I remember doing it. I mean, I've been there. I still, even with HRT on board, I still have the rage sometimes. And it's distinct. It's like
it takes over your body.
The words are coming out of your mouth. You know what's happening and you can't stop it. No. You're just like, or maybe you're just like, fuck it. Yeah. Just going to let it go because it's built up, but it's crazy. It's a big one. And you're right. There's so much shame around it. And I think the insomnia piece is huge. I was always a really good sleeper too, not Kuwait level sleeping, but like I could sleep. And I was a huge fan. I love sleep so much.
Yeah, so do I.
And I covet it. And all of a sudden, what I noticed? It was 2019 and I met my current husband. I was single, I was dating, and I met my current husband, and he's a farmer, electrician. He has reared animals. So like he gets my weird naturopathic ways. He understands lifestyle medicine comes first in our house, and, diet, nutrition, and all of those things matter. And usually I have to sort of coach the guys I'm dating into understanding my methodology. Like, we're not going to heat our food up in plastic. We're not going to, use the toxic cleansers in the house, all of those things. And he was already on the tip, so he got it. And then all of a sudden, a few months into us dating, he's like, we need to have a talk about your sleep. And I was like, what are you talking about? I'm like a champion sleeper. He's like, not really. You wake up a lot and you're up for a few hours and then you come back to bed. Like, what's going on with that? And I was like, I don't know. And it would be about once a month, and it would be around my cycle. I started noticing the correlation. And what gets me is that women will literally go from that to full-blown insomniac to living with chronic insomnia for the rest of their life and never get intervention, never get hormonal treatment, get prescribed terrible drugs like Ambien. And meanwhile, their metabolic health is falling to shambles because their sleep has been so terribly disrupted. And it's just like, this is criminal.
It's like a form of suffering. I remember seeing this Instagram post. So we're going back to like 2019, 2020. And it was a woman in bed, and she like sits up in bed, and she's like, and the joke is she heard her kid 2 states over. Right? Yeah. And so the joke was like, being a great mom means not sleeping and being worried. And that's part of being a great mom. You know what I mean? So we kind of like bring these two things together, that like this is suffering, whether that is worrying about our kids, having rage, anger, not sleeping, pain during, labor, is somehow tied to how we see ourselves and value ourselves as mothers.
Yes.
Therein lies the problem.
Yes. It's like a badge of honor too,
yes.
that they can suffer through it.
Mm-hmm.
It's very
I don't
interesting.
sleep because I'm worried about my kids, and I can hear my kids, 3 offices down or whatever. That's no.
Meanwhile, I'm like doubling and tripling up on my progesterone, so I knock out like a horse on
How much
ketamine.
progesterone can I take?
Which isn't always
wake
great
up in the
because
morning.
the next thing, you're groggy in the morning, and the next thing I know, I'm like, I've got the carb munchies so bad because I took too much progesterone. But man, it's good stuff.
I hear you. I love it.
I actually, I like to use it intravaginally too, because I get a little bloated, and I know patients complain of this. They can get some bloating and they can get some weight gain with it. So I'll do like one orally and one up the hoo-ha, and just kind of even.
I have some patients that use it rectally.
Yeah.
I have some patients that don't love it, how it feels vaginally. They feel like it's like falling out. And I was trained in Europe. We give everything rectally. Like we give all kids, their Tylenol and their whatever. We like deliver that rectally to young children routinely. And so I'm just much more comfortable with that, route. And if a woman is comfortable, and oftentimes they will be, if you talk them through it, they will often do that, because once it's in there, you just don't feel it anymore.
Does it change their, I've never used it that way. Does it change their bowel habits at all? Do they notice anything?
Not really. And it's really well absorbed.
Oh yeah, that's amazing. I think rectal was big when I was a kid too. It has definitely gone by the wayside.
Changed. Yeah.
I do still love the fact that you can get some things through compounding pharmacies and be able to deliver them rectally. But okay, so let's talk about some of these myths. Let's first, you don't have to, go in too deep, because I think my audience has heard me rant about that the Women's Health Initiative study. But you did a great reel the other day. Let's do a breakdown of what was wrong in that study.
Yeah. So what was wrong with that study, the main issue with that study was what they used. And this is often the misconception that people have. And people will quote, cardiologists will quote and say, oh no, you can't take HRT because, it's going to increase your stroke risk or your clot risk or your risk of having a heart attack if you're 10 years past menopause. And that's not qualified with, but what did they use? So I spent a lot of time educating people so that we all understand what they used. And we know that they used oral Premarin, oral conjugated equine estrogen, which is not the bioidentical estrogen that we normally use and not the route we would normally use. And they used medroxyprogesterone acetate, which is a progestin. This is another thing that I rant about on the internet, and the difference between a progestin and a progesterone. So the major problem with the WHI is that they use drugs that we are not using routinely. I mean, occasionally we do in certain circumstances, but routinely we are not using those drugs. So to extrapolate data and say that this is going to increase your clot risk or heart attack risk when you're comparing a completely different approach to treatment is like apples and oranges.
Yes, absolutely. And then the cohort that they put those hormones into, those were older women.
Older women.
Yep.
So the cohort of women were significantly older. They recruited women all the way up to the age of 78. The average age was in their early 60s. So we're talking about a completely different age group than we are initiating hormones now. So back to our initiating hormones in women that are older, that probably have developed a little bit of cardiovascular disease, probably because they've been without their hormones for 10, 15, 20, 25, 30 years, even for some. And so some of them, you gave them oral conjugated equine estrogen, and some of them clotted. Wow, I'm so surprised by that.
I did see you talk the other day about that you're very comfortable giving older women hormones. Can you address that?
Yes. So for this reason, when I see older women, they come and see me. They feel that it's too late for them. They've missed out. And we talk about the WHI and what the WHI showed us, because we know from the WHI that not in terms of cardiovascular prevention, yes, if we don't initiate hormone therapy early enough, then we probably miss out on the greatest prevention benefit for cardiovascular risk. But they're going to sleep better. Their GSM is going to improve. Their bone density is going to improve. Their relationships are going to improve. Their mood and their anxiety is going to improve. So okay, fine. We can't get that same preventative benefit as if we started it earlier, but there's all these other potential benefits that we can gain by initiating hormone therapy. And I really don't believe that transdermal estradiol or vaginal estradiol is going to destabilize existing plaque. And I routinely treat women with cardiovascular disease that have a stent or a history of SCAD or whatever, or a history of a stroke with transdermal estradiol. And I personally believe it is perfectly reasonable and safe to do so.
Yes, I agree with you. Absolutely. I think it's just torture. I truly,
Totally.
I think it's torture withholding it. It's
100%. And, whenever I post about stuff like that, I always get women in my comments and my DMs, and they'll say to me, I don't even care if it increases my risk.
right.
My life is so bad right now that if anything can help me feel better, I don't care if it reduces my lifespan by 5, 10, 6, which it's not going to, but I don't even care if it did.
100%.
And I see the same thing for women that are breast cancer survivors. They're like, I would rather die 5 years earlier than survive another year like this because I cannot live like this.
I completely agree. I don't think I'd be here either if I hadn't slapped that estrogen patch on. I truly don't. I mean, the progesterone was very helpful, of course, but man, I was brought up using progesterone topically since my 20s. Same thing, PCOS. I mean, my mentor taught me it doesn't matter what age, you suspect PCOS and you do a trial run of topical progesterone to see if you can at least make those periods better and at least make that menstrual cycle nicer. And then of course we test and we follow up and we make sure, but this is a little bit more in the olden days, but he was very much like treat assumptively, follow up with labs and make sure you're being safe. And total game changer, but then having to go, I really had to switch to the oral. I mean, I was time, I was in that phase, but I don't think I'd be here. And I absolutely 100% would not be able to tolerate the pain I was in. I remember looking at my husband and I was like, I can't imagine. I'm only, at the time I was like 47, 48. And I'm like, what is it going to be like when I'm 80? Like, I can't do this. I can't be here. I can't keep doing this. And forget the flat affect and the depression. I think the pain was driving that even more, but the pain itself was unbelievable. And what I try to tell folks is we all present differently. We all have different hormone receptors. We all have different symptomology when our hormones leave the body. And it's not fair to compare my experience to your experience to the lady who had no problems and whizzed through and is now on 5 other pharmaceuticals. It's totally individualized to the person in front of you. And I dose that way too. I know the Menopause Society says, and we've got to get serum levels up to X amount to get the bone health. I don't hang my hat on that as much. I really am looking to abate symptomology and make sure, because most of the people I'm dealing with have musculoskeletal pain. So that's, how do you feel about that?
I would agree with that. I treat very much symptom driven, but I do like to use the labs because I find some women just aren't absorbing. And if I'm suspicious about their absorption, then I will hang my hat on some labs and be like, okay, I'm suspicious that this is not actually crossing at all. And I'll, change the modality or the route or whatever we're doing. So I would say I do, I am all about listening to women, and the woman will, she's going to tell you the diagnosis if you just shut up and listen to her. And, that I truly believe that's how I was trained. And if you listen, she will tell you what the problem is. And then if you can find a way with her hormones to help her, you can resolve all of her symptoms generally if you would just listen and then craft a very individual approach that is for that person. I wanted to touch on something you said. You said about treating women, assumptively right out of the gate. And that's something that comes up. But, by the time women find me, often they've seen 6, maybe 7 doctors. And I've had women say to me, please don't send me out of here with nothing. I cannot. Please don't send me out of here with nothing. Because they've been sent out and, we'll do labs and then come back and we'll talk about it. And I don't do that. I think if I suspect that this is hormonal or whatever it is, I'm going to treat it. Yeah, okay, fine. I'll back it up with some labs, but I'm going to treat it because if you feel better, there's the answer.
And we can do that legally as long as our chart note reflects it and the history is there. And you're so right. I was taught the same way. Your patient will tell you what's wrong with them. Your patient will point to it. If they have a musculoskeletal issue, they will tell you exactly what's going on. If you just follow the lead, right? And take a good history and do
There's studies on this where if about how soon after the initiation of the consultation, the doctor interrupts. And it's like 19 seconds, I think, on average. And I was taught you have to be quiet and let them finish their opening gambit. And because they're going to tell you everything. But people don't do that. And people are always surprised when I'm just sitting quietly listening to what they're saying, because that's my job, is to listen to what you're saying.
Yes, I love it. Well, that's so cool. You were trained in Europe. That's wild. That's so great. What a wonderful perspective to bring to your patients, because I don't think patients realize that, the systems are the way the systems are. And I'm sure they're very different in different countries. So
Yeah. And I was trained in the UK, and in the UK, it's a nationalized health service. And GPs, which is what I was trained as, are the only doctor of the community. So we don't have like pediatrics or gynecology, or that doesn't exist in our community. They're in secondary care. So you have to manage everything. And then if there's something outside of your wheelhouse, you refer into secondary care. So we were seeing everything and a lot of it. So, you saw a lot of pathology. And at the end of the day, that's what makes you, the best clinician is the more you see, the more you understand.
do you look back now on your experience and think, man, I missed a lot of hormone cases?
Oh, yes. And sometimes I'm just thinking about it, I'm mortified.
Yeah, me too. Me too.
Mortified at the things I said to women
Yeah.
about their hormones.
I just remember thinking, because really, I've dealt with pain. Most of my patients came to me because they were in some form of pain, physical pain. And I always told them, it's not my job to judge your pain. The way that your body is transmuting pain is the way your body's doing it. And it has nothing to do with the way that, it's kind of the same way with GLP-1s and weight. People are like, oh, just tough it out, just do better and work harder. I love that we're telling middle-aged women to work harder when we have worked our butts off our whole life, raising children, running the household, always, most of us have had careers. Anyway, I miss a lot of mental, emotional stuff. I also had a hard time with patients in that I was happy to prescribe hormones, and yet their GP was scaring the crap out of them. And everybody was telling them that the hormones were going to kill them. I'm sure you get these people on Instagram too. People call me a murderer sometimes in my comments. And I'm like, are you insane? Like, just go read some data, like go away. But these women would believe whoever was, maybe their OBGYN, whoever it was, telling them absolutely not, don't take it. I just had a patient recently whose doctor, it's crazy. She was going in for surgery. And I had a friend this happened to too. They were going in for surgery and the doctor was like, if you don't discontinue your transdermal estrogen patch, I'm not, because you're going to get blood clots and potentially die. And I'm like, what, are you guys like not keeping up with isn't that our job to keep up?
Yeah. But, women feel stuck. They're like, I have to, when it comes to, I had a very similar case. A woman recently, she had to have surgery. She had a fall and she ruptured her hamstring and had to have surgery. And we were kind of back and forth on the portal. And she said, oh, they want me to stop my patch. And I said, you don't need to stop. And I sent her the link and I said, give me the name. I will send them the articles. And I sent everything and they still made her stop. And she felt stuck. Like they're not going to operate on her if she doesn't stop this patch. So she stopped it. And I just think, women are it's ridiculous that we're like making shit up.
The thing that gets me about the musculoskeletal part, and you said something earlier that I want to come back to. I only waited like a year and a half too long before I got that steady, I call it steady state estrogen. I was using topical, it just wasn't absorbing. And so I went to the patch. It took me about a year and a half to really figure that out, that was what was contributing to my pain picture. And from everything I've studied, and I'd love to hear I'm such a nerd when it comes to musculoskeletal pain. Like that's really my wheelhouse. And from everything I've studied, it sounds like it's the estrogen swings that really contribute to the pain pattern. And B, sometimes we can get too far behind the ball, and applying estrogen in some studies showed improvement in pain and in some studies showed worsening. And so I think that bone, ligamentous, tendinous, soft tissue picture can shift to such a degree that now I am in a chronic inflammatory pain state. And even with the transdermal estrogen, I still can't get back to baseline of where I was before it all started.
I would agree. I think you can get too far and have not just your tendons but be so inflamed, maybe your gut that the estradiol makes really not a lot of difference to it. This is where I think GLP-1s are like magical because they're going to give you that additional little bit of anti-inflammatory benefit and testosterone. Sometimes you have to layer one thing on top of the other to really get enough anti-inflammatory benefit to really move the needle on pain. But I completely agree with you. I think you can get so far behind, it's really, really hard to rescue the situation.
Yes. And I'm thinking of myself and the pain I had, and the short amount of time I was in it overall, if you think about it, it could have been the rest of my life if I had been born 5 years ago or I didn't know what I know, right? And I wasn't able to advocate for myself. But I think of these women who were in my practice who must have been in the most exorbitant amount of pain, because they would often find me in their 50s and 60s. And they were postmenopausal, and I would like plead and beg with them to just consider, let's try a trial run of HRT. And they would vehemently, you had to give them an endocrinology lesson to even get them to think about it, because it was like, no, that's going to kill me. They had that in their head. But the amount of pain that these women must be living in, and then as women, we just like learn to accept it and shut up, right? We don't complain. And what these women don't realize is that their experience of pain is completely separate and distinct from everyone else's because of the way their brain is wired. And it could have everything to do with adverse childhood events. It could have something to do with a gut infection. It could be a million things, the way that their body is presenting their pain or lack of. And the same person over here is like dying of they scratch their finger and their pain is so pronounced and overzealous, and it's a whole, their central sensitization is all wound up. Pain is so, what I have learned about pain over the years has been so sobering and humbling, because I was always like, I have a really high pain tolerance. And then all of a sudden I was met with chronic pain that just kept on and then got worse in perimenopause. And I'm not even menopausal yet. And I'm like, oh Lordy.
And I remember, I worked in the ER for a long time. I worked in orthopedics. I worked in urgent care. And historically, I cringe saying this out loud, and it's shameful. But, seeing somebody, always women, and she's in pain, and you would come out and be presenting to your the other doctors, or, and be like, she says she's a 10 out of 10, but, she's sitting there comfortably. We just are so dismissive of women's pain. And this is somehow rooted in the way that we are taught medicine. We would never behave like that around a man, or somehow dismiss his 10 out of 10 pain as always making it up. It's in his head. And
women of color get it worse.
Totally.
It's wild. Yeah, it's wild. That's why I love your account, because you say all the things. It's funny because I'm sure you notice this. When you get to about 100,000 followers, they come for you, right? They really come for you, and you never wavered. You didn't shift. I watch most people get a little more tempered. Yeah. Once you get to like almost 400, they really come for you. And my style on Instagram is a whole lot calmer than it used to be, because I used to just be in your face. It was a lot more fun back then, but you never shifted. You come on, you're doing your skincare, and you're like, we're going to talk about what happened today. The nonsense the nonsense story my patient told me that they got told by their doctor.
Yeah. Well, social media is a weird place.
Isn't it?
It's bizarre.
What made you go on there?
Every day I'm like, why am I doing this? Like, what is the point of this? So I was never a social media person. I had a Facebook when I was, a lot younger and, after college. And then I canceled my Facebook. I've never been a social media person. I'm actually a very private person. I'm not a sharer. And when I started Lifestyles, everybody was like, oh, well, for marketing, you're going to have an Instagram and a Facebook. And, I said, okay, all right. So, I set up my Instagram and the Facebook and then eventually they talked me to TikTok so that, I could market and people knew where I was. And that's the only reason. And I started to put stuff there, and it just went. And I wasn't expecting that. That was never my goal. So every day I'm like, what are you doing? Or like, do we want to do this? What's the point of this? But it's fun. I enjoy it. I do, people send me DMs, and I meet people, out and about every day, and they tell me that, things that they've heard me say has changed their life, and they were able to get the care and advocate for themselves. So I guess it's for something, but it certainly wasn't planned.
Well, your work is really important. I think it's such a tempered, logical approach. It's like you're in the trenches, you're doing the work, and you just say it how it is. And that isn't always super popular, Popularity online comes from being really polarizing. And I think there's a couple different camps in the hormone space that are very, very where they are. And I'm always sitting in the middle, and I'm like, you got to go to the gym, ladies. You got to go to the gym. So
gotta lift things.
Yes. Let's talk about that, because I saw you goblet squatting a big ass dumbbell the other day. And I was like, that's when I invited you on the pod. I was like, we got to get her on.
I love to weightlift. I historically, I was not a weightlifter a long time ago. In my 20s, I posted about this. I was a step aerobics girl.
That's fun.
I still love step aerobics. Give me a sequence, like some choreo, and I'm there. So I was that girl. Lots of aerobics that I loved. And then I had this, and I posted about this a little bit, but I had a really bad back injury. So when my son was born, he's 16. When he was 6 months old, I had him on his changing table and I was changing his diaper, and he was like, 6 months and wiggly. And he actually fell towards me off of the changing table. And I caught him in a way and immediately had pain on the right side of my back. And then over the next few years, kind of, I would have that really acute 10 days of I can barely move sort of pain. And then it would like work itself out and I'd be okay. And I was a resident. I was working like 100-hour week. I did not have time for back pain or to get help or do anything about my problem. Then I had my daughter, and on my 31st birthday. And when she was 1, we went to pick up my son from school. And there was another mom, lots of moms there. And another mom had her dog, which was a spaniel puppy on a lead. She had him totally under control, but the puppy sort of like, Ava was tiny. She was a year old, and I was holding her hand and she was like toddling along. And the puppy sort of like sprung towards Ava, was not close enough to get to her. The woman had her under control, but I sort of panicked and grabbed Ava and immediately had searing pain down my right leg. And over the course of the next few days, I was unable to walk. I lost the ability to use my right leg. And I ended up, they thought I had caught equina. I was in MRIs and all of this emergency stuff, thinking there was something really wrong, but I had slipped 2 discs. And after that, I took over many, many years, I recovered. I was offered surgery at the time. I was afraid. I was working. I didn't have time. And I moved around that time, I moved to the US, and I was still doing my aerobics. And then I decided, you know what I need to do? I need to do Pilates. That's going to help me. And so I started to do Pilates and bar and all this stuff. And my pain was not better. It was getting worse. And I ended up seeing a PT very near where we live. And she saw me and she was like, everything you're doing is wrong. What are you doing? I need you to stop doing Pilates. I need you to lift weights. And I thought, I can't lift weights. My back hurts. What are you talking about? I can't lift weights. And she said, just trust me. I'm going to help you lift weights. And if I don't lift weights, my back hurts. Heavy weights. And if I don't lift weights, I get my sciatica pain back immediately. So it's like a harbinger. I was like, oh, no, I'm not lifting enough, or you're not lifting heavy enough or frequently enough because your back pain is back. And people think that's so surprising. And after I posted that last week, after that conference that I went to, people reached out to me and DM'd me, really? It doesn't hurt your back? And I said, no, as long as you're with somebody that can teach you how to do it properly, you can really change the course of your back pain with weightlifting.
And change the course of your life.
Totally.
I mean, it's just non-negotiable. And I've been, I came online in 2016, and I was just beating the drum, like deadlift and eat steak. And it was not popular because the health gurus of the time
were in the plant-based world.
Yeah, they were like, do yoga and go vegan. And I was like, eat meat and lift weights. And it was not popular. It is popular now.
Yeah.
And I'm so excited that it is. But I have a program where it's an online program where I teach women how to strength train beginners. And it's amazing. Every time I post about it, the amount of whataboutisms, pushback, and women arguing for their excuses in the, and their limitations in my DMs is just bewildering. Because I'm like, this is like, I saw a doctor the other day. I actually reposted her. She was on a podcast. I can't remember her name, but she said, if you're not willing to lift weights, you might as well just start picking out your nursing home.
It's true.
And people wrote me back and they said, you're fear-mongering. And I'm like, no, I'm not. I stand by every word she said.
It's true.
Yeah.
And I've seen it. I've taken care of those women. My entire training and the start of my general practice training in the UK. So the way that each of the clinics would cover a certain catchment area, and any nursing homes that were in that catchment area were our responsibility. So every day we would be rounding in the nursing homes and, taking care of people and seeing people. And let me tell you, all of them were women. And all of them were fallers. Frailty is the reason that women end up in nursing homes. And the only way to combat frailty is to lift heavy things.
Amen. It is it. This is non-negotiable for everyone listening. You have to find a way, the information's out there now. There's so many online resources.
There is so much, yes.
This is not, I call it my little granny lifting because I have severe back issues myself. And so it's my little granny lifts, and I focus heavily on my glutes. I focus heavily on my lower body because that is how we are going to build the biggest mop to soak up that blood glucose and the blood sugars and regulate our metabolic health. But it's just not, It's for everyone. It's not negotiable. You don't have to be throwing around big weights. You don't have to be CrossFitting or high roxing or any of that nonsense. Just lift your little weights, do your little thing. And I shouldn't say little because I am a big fan of heavy too. And right now, I don't know if you saw the American College of Sports Medicine just released their guidelines. And it was the first time they've released guidelines in 17 years. And what came out of that was really encouraging. It was basically, and I'm going to have the main author on the podcast here soon, but basically, whatever tools you have available, whether it be bands or dumbbells or the gym, or it doesn't matter, all of it counts. Consistency is the big take home of what they were trying to drive home, is like consistency counts more than anything. You don't have to lift heavy. You just have to lift consistently. And I think that's a really nice message. But as a chiropractor, I will tell you, there are aspects to the central nervous system that when you lift heavy, it's a hormetic womp. And it does really good things for all your neurotransmitters and your nervous system. And we don't have a lot of science behind it, but I've seen it, I've experienced it.
Oh, you felt it.
Yeah. Like there's something about going heavy or going home, because the little dumbbells, and not to say there isn't a place. Every time I injure myself, and I've had some pretty big setbacks in the last few years, that was the other thing. All my tendons and ligaments started ripping when my estrogen left. I ruptured both of my Achilles. Like boom, boom. And then I herniated a disc and I was like, what is going on? I can't recover from any of this. And like I said, I went into this in the best shape of I was like about to test for a Strong First kettlebell certification. I was in amazing shape and very little body fat and just ripped. And everything starts tearing on me. And my poor strength and conditioning coach is like, what the heck is wrong with you? You keep tearing. So I understand there's some hurdles, and that's why we're talking about hormones today. But the actual act of, getting back to it, I did have to pick up the baby weights. And so we all start somewhere.
That's okay.
Yeah. Because heavy for you is different for heavy for me. Like I can't goblet squat what you're goblet squatting right now. I used to be able to. And when I saw you do it, I was like, yes. And it was so inspiring because I know I can get back to that. But I'm over here with my little 40 pounds and I'm feeling pretty amazed because it was 20 pounds a few weeks ago because I was coming out of this injury. So anyway, I just share that because I want the audience to hear it. I want them to, this is.
And also they're all worried about the aesthetic, I'm going to get big. I mean, I've got with goblet squatting 65 pounds. I don't look like a weightlifter.
No, you're very lean.
I love it. But I don't look like a weightlifter. So, they're worried about how it's going to look. And I'm like, I don't know you're going to look great.
Yeah. Everybody looks great. I live north of North Scottsdale. I live like way up from there. And I go to this gym in North Scottsdale and it's all these really thin women that are our age and maybe a little older, maybe a little, but generally like just middle-aged women, very, very thin, absolutely no butts whatsoever, and fake boobs. And there's no women in the gym area or like in the weight area. There's a couple younger women with really great body composition, but everyone else is in the Pilates room or the spinning room.
On the treadmill.
Yes, crazy on the treadmill. And they're all so skinny and have no butts. And I joke with my husband when I go in, I'm like, I'm just looking for some middle-aged women with some glutes today. I'm going to go high five them and be friends because that's all I care about.
And because the glutes are what's going to get you off the floor when you fall.
Or keep you from falling.
Forget about how it looks in jeans.
It looks great in jeans though.
It doesn't even matter. It's about getting up.
I know.
When you fall.
Or not falling. Like having those fast twitch fibers when you step off the curb wrong. I can't tell you how many of my patients broke hips because they stepped off a curb wrong, a freaking curb. It's like one little thing and all of a sudden they're, snap. And the bone's waiting to go. It's not it's not always the fall that causes the fracture. The bone's already compromised and then whoop.
And then it's downhill from there. I always, whenever I'm presenting and I'll, speak to the women in the room and I'll say, I want you to think about all the older women in your life that maybe have passed away or are still with us who are, in poor health. And can you think of somebody where it started with a fracture? Oh, she fell and she, broke her knee, or it was a tibia, or it was a humerus, or it was, they don't necessarily die of that. And that might not be 5 or 6 years until they die, but it was often the catalyst. It took away their independence, it took away their mobility, and they very slowly deteriorated from there. So on her death certificate, we're not going to have humeral fracture, but if you walk the sequence of events back, it often was the humeral fracture.
That's so true and really tragic. And the fall on an outstretched hand, breaking the radius is so common. And when I can't, the amount of women in my life who've fallen down and they're like, I broke my radial head. I'm like, you have osteoporosis.
I know. And we have ice here. I live in the Northeast and, always there's women going to the grocery store. I want to ask them all, have you had a DEXA scan? Have you had a DEXA scan? Are you on hormones? Because they've got their arm in a cast and they've clearly had a Colles fracture. I'm like, what happened?
Yeah.
Can I help you? Can I give you some hormones? Do you want my patch? Can I help you?
I feel the same way. I want to take all these little flat-butted women and just take them over to the glute hip thrust machine and be like, because like you said, falling, I was, okay, so for my 42nd birthday, I rented out the roller rink in Portland because I wanted to like make the playlist. I wanted my own songs and I rented the whole place and I invited all my friends. And very few people would get out on the rink with me. And I'm hauling around the rink. And at one point, I just bit it. I just wiped out. But my glutes were so well developed, I literally bounced off of them and just came right back up. And everyone's like, how did you do that? How did you not break anything? I'm like, dude, glutes. Just glutes. Just focus on the glutes. Your butt will look good. Yeah. Your hips will work better. It's just the easiest thing to do. And then you'll feed yourself appropriately because you want to build more gorgeous glutes and it's a thing. So, and the whole squatting thing, the women need to be squatting and I really firmly believe we need to maintain our Asian squat. We need to be able to go ass to grass and we need to be able to hover over a toilet without touching anything. Like how many women our age can do that still?
Not many, hardly any.
Yeah. And just being able to get up off the floor, right? A lot of women lose that ability in their 50s and 60s and it's gone forever. They cannot get up.
It's so not in our culture, but if you travel to, places like Turkey and, some parts of Asia, they still have the hole in the floor sort of approach to passing urine and opening your bowels and you'll have to squat.
Yeah.
I'm like, it's great for your hips. Keep doing it.
Yes. Well, I have loved this conversation so much. I don't want to keep you all day. I could talk to you for hours. Please tell everyone where they can find you, your Instagram, your website, your clinic.
My Instagram is Ask Dr. Noor. It's on TikTok and YouTube. And then my practice is lifestylesbynoor.com. I'm online. And then my personal website is drnoorwellness.com. So we're in the process of building that out and fun things are coming.
I love it. I love it. Well, I will make sure everything is in the show notes for everyone to find you because you're such a wealth of information and I appreciate you making the time today.
Anytime. Thanks for having me.
Thanks for listening to the Dr. Tina Show. This is a Wellness Loud production produced by Drake Peterson. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.